class. So it is my honor to introduce Dr. Carrie Inwards from Mayo Clinic. Dr. Inwards is a well-known specialist in the pathology of soft tissue and bone. She graduated from the medical school at the University of North Dakota, and then she joined the staff, the house staff initially at Mayo Clinic, where she completed her residency, and then she followed that with surgical pathology fellowship also at Mayo Clinic, and then she joined the faculty, where she stayed, for her entire career. She is a member of many organizations, and most importantly with the International Skeletal Society, where she is an active member and very productive member too. She authored more than 70 papers on soft tissue and bone pathology only, and she also co-authored 2 textbooks on bone and soft tissue pathology, one with Dr. Falk, also from Mayo Clinic, and the other one on is the Darling's bone tumor with Dr. Uni. So please welcome Dr. Inwards today. Thank you.
Thank you, Emil. Well, it truly is an honor to be asked to give grand rounds here today, so I thank you sincerely for this invitation. It seems like coming and visiting a cousin, Mayo and the University of Minnesota. It's kind of, in some ways, old home week for me as well. Having been at different conferences and my residency and the pathology ties too. I mean, I go back to my residency interacting with Mark Wick here when he was in the pathology department. He trained at Mayo as well, before me, but Mark Wick, and then through the years, of course, having an interest in bone and soft tissue, Carlos Manival, and some of the other pathologists. And now I'm delighted to be sharing cases with Emil and Pari. A lot of challenging problems, and so I'm always grateful when they share those cases with me. So again, thank you for the warm welcome, and it's truly an honor to be here. So let's get started. The topic, or my title of this discussion is Chondrosarcoma, Evolution of Diagnostic Concepts. No financial disclosures. So in the realm of, in the bone tumor world, hyaline cartilage tumors are relatively important because they're very common. They happen to be the most common primary tumor of bone. But the differential diagnosis is rather short on the benign end, Enchondroma, comprising about 10% of hyaline cartilage tumors, and chondrosarcoma approximately 15%, so relatively common. But even though they are common, they comprise a group of diagnostic problems that over time continues to be one of the most difficult diagnostic challenges for a surgical pathologist, and particularly those in the bone world who get funneled these cases, and we try to sort through the differential diagnosis. It's challenging in the differential between enchondroma, benign, and malignant grade 1 chondrosarcoma as well, the different grading schemes. So it's one of the reasons I chose chondrosarcoma, because in the bone tumors are rare, but at least in that realm, chondrosarcomas and enchondromas are fairly common. So in the next, about 45 minutes, I'll try to leave room for time for some discussion. What I'd like to do is begin with a case presentation. And from there, I'm going to segue into a discussion about essentially a diagnostic approach to these cartilage tumors, encompassing the clinical features, histology, and radiology. What are the implications of our diagnosis, and are there any ancillary studies that may be helpful? And then I'll close with the another wrapping around back to our case discussion and look at a few things that might be evolving in the future as this whole issue of diagnostic concepts. Now, I'll also be throwing in some things from a historical perspective. And this title, Chondrosarcoma, Evolution of Diagnostic Concepts, is the title of a paper that my colleague Dr. Carter and I published a couple of years ago. And in doing so, and sitting back and trying to see, where were we and where have we come, I found it very interesting to dig through and read a lot of the old articles of the people whose shoulders we stand on, And I'd read those years ago and appreciated them. Didn't read all of them, but kind of went through them. But I find out my later stage in my career, I even much more appreciate what they wrote and how well they wrote, and sadly how much we really haven't come all that far in some ways. But some elegant writing. So as I quote some of these papers, I encourage you at some time to enjoy reading them. So here's the case I'd like to begin with. This is a case that I saw a couple years ago, a Mayo Clinic patient, and it concerns a 9-year-old boy who presented with left-sided facial droop and left-sided hearing loss. So the imaging, as you can see here, CT scan showed a lytic lesion in the mastoid portion of the temporal bone. Okay, so it's lytic. There's a little bit of cortical destruction here. No soft tissue mass, but erosion. The MR showed characteristics that are typical of myxoid change. Now, the musculoskeletal radiologists, when they read this, they said, you know, we're concerned about a cartilage tumor. But people who don't see tumors, the radiologist in the head and neck area said, you know, this could be cholesteatoma, maybe a cyst, maybe a scar. So quite a different differential diagnosis, which emphasizes sometimes when you get people in different disciplines who are interpreting imaging in an area that's not quite in their purview. So the surgeon who saw this patient, the patient had a lot of symptoms, and he decided, well, I'm just going to go take this out. So fortunately, there was no biopsy. We got a lot of tissue as they excised the entire lesion. And here it is. Not surprising with the title of the talk. It's a hyaline cartilage tumor. So you see lots of cartilage, and this is a piece of host bone that's just kind of floating in this tumor bed. On higher magnification, there are some areas that are, I'd say, hypo to moderately cellular. Nuclei aren't all that big. But then in other areas focally, we begin to see some nuclear enlargement and increased cellularity, kind of merging with this less cellular area. So there you go. We'll get back to it later. At this point, I'd like to, again, address the issue. We know this is a hyaline cartilage tumor. And again, there's only really two choices. Is it benign or is it malignant? All right? So as we think about this case, this is how we'll go into any hyaline cartilage tumor diagnosis. And we'll start, as with really anything in pathology, you need to get the clinical information and the histologic features and get all that together and start formulating your differential diagnosis. But in the realm of bone tumors, the radiologic information is absolutely essential. Absolutely essential. I can't emphasize that enough. Because you really, probably have heard this before, you should never make a diagnosis of a bone tumor without knowing what the imaging shows. Now, what does that mean? Well, it means you could read the report. That's okay. It's better than nothing. But I found in my practice, there's nothing like a conversation. Picking up the phone, it's sometimes not easy. You leave a message. They call back. It gets persistent. You don't see that many bone tumors, but it will save your hide if you make that effort to get good information on the imaging findings. I can't tell you how many times I read the report and I get some kind of an idea, and then I talk to the pathologist, and then there's the nuances. And we understand that as pathologists, the nuances. And that is just so important. I've just saved myself by conversing with the radiologist, and you can't text them. You gotta talk on the phone. And so, in my practice, of course, I see a lot of bone tumors. I do general surge path too. I rotate in the frozen section, but my subspecialty area is bone tumors, and I'm on the phone every single day with our radiologist talking about cases. So, radiology is important. But for now, let's get back to the clinical information and histology. We'll talk about radiology later. Okay, so clinical information. This is a hyaline cartilage tumor, so we'll talk about it in terms of our differential Enchondroma. And of course, if the two things we're going to look at here in the big picture is the age distribution and the skeletal distribution. And you can see that for Enchondroma, this is data on 424 patients treated at Mayo Clinic for Enchondroma. There's a broad age range. Majority are in the first 6 decades of life. But our patient is 9. And here we see in the first decade, wow, there's like maybe not even 1% to 2%. So that's a little concerning. If we look at the skeletal distribution for Enchondromas, we can see that the majority are in the small bones of the hand, followed by the proximal ends of the long bones, not many centrally, and look at this, none in the craniofacial bones. So now we're saying, wow, well, this can't be an enchondroma then, can it? Well, I never say never, but already the demographics aren't looking good. What about chondrosarcoma? In this group of 1,073 patients who were treated at the Mayo Clinic, again, a broad age distribution, but a little bit more shifted toward an older age group. And look at this, like under 1%. I don't know the exact number, but even more rare than enchondroma. And if we look at the skeletal distribution, we can see that, well, there's a few more up here, but when you consider out 1,073, not that many. Where do chondrosarcomas tend to occur? Well, they occur centrally. You can see a lot in the ribs, but at the ends of the long bones. That's where they tend to cluster. So when we talk about anatomic distribution with bone tumors, the other thing to keep in mind, other than is it in the femur or in the the skull, is where in the bone. And as you learn more about bone tumors, you'll find that your differential changes. Is it in the epiphyseal portion of the bone? Is it in the metaphysis? Is it on the surface of the bone? In the vertebral body? Is it in the posterior elements of the spine? If you get that information, it's going to help you arrive at the correct diagnosis. So you get that imaging, of course, from the imaging findings, and you'll be talking to the radiologist, so you'll be able to get that. So let's move on to focus on the histologic features. And in that general category, we're going to talk about how we make a diagnosis and then grade these chondrosarcomas if it's malignant. Let's focus on diagnosis. So if you look at cartilage tumors, these are really the 4 histologic parameters that we assess when we're looking at bone tumors: cellularity, cytologic atypia, host bone permeation, and myxoid change. Okay, so depending upon the amount of tissue you have, of course, it's variable as to how much you can assess for these features, and we'll see that in these cases that come up. Let's first focus on cellularity and cytologic atypia. So this is the first real discussion and description of chondrosarcoma as far as I'm concerned in the literature, and it was a paper published in 1943 by Drs. Lichtenstein and Jaffe, East Coast gentlemen, and they're giants in the field. Some would say they're just the forefathers of many of the different descriptions in bone tumors that came out of their publications. And in this 1943 article, based on their assessment of what they diagnosed as chondrosarcoma, they said that the diagnosis should be based on identifying plump nuclei, and many of them, any giant cartilage cells with multiple nuclei or clumps of chromatin. So to my eye, plump nuclei and this description means cytologic atypia, and many cells means lots of them. So there you go, cellularity and cytologic atypia. They also talked about more than an occasional binucleated cell. That parameter, I think, has kind of fallen out of favor. You could probably lump that, I don't know, into cytologic atypia, but these two are still the gold standard for what we use in some of our criteria in trying to determine benign, malignant, and even grading. Okay, well, with that in mind, let's take a look at a case. Here's a 43-year-old male. You've got this slide, and you're told it's from the proximal humerus. Well, in the realm of cartilage, I think it looks kind of cellular, and there's some enlarged nuclei. And again, I don't count the nuclei. It's kind of like, I think, with liposarcomas. You don't really look for lipoblasts because there's a lot more hints in other things other than looking for lipoblast. So skip the binucleated cells. But anyway, I digress. Increased cellularity and nuclear enlargement. So easy. Is chondrosarcoma? Well, here's another area of that tumor. And boy, does that look benign. Hardly any cells, and they're all small. Well, now what are we going to do? What is this thing? Well, we're going to go to the imaging, and we're going to see that it's an enchondroma. And this case illustrates that even though we're going to look at the cytologic atypia and the cellularity, it's not all that simple. And the reason is because of the heterogeneity in these bone tumors. And what you need to do is get an assessment, a gestalt, for the overall cellularity and amount of cytologic atypia. And of course, what that means is sometimes it's really nearly impossible on a limited amount of tissue. Because the same could be said for a chondrosarcoma. I could have put actually a picture here of a chondrosarcoma and said this is a chondrosarcoma, because you can get areas in a chondrosarcoma that can even look that bland. So those two parameters are important, but you have to put it into context. What about host bone permeation? Well, it was mentioned in the literature, but I think the first paper that really delved into it was this one by Dr. Sanderkin, published in Cancer in 1980. And went on to talk about more detail, what is host bone permeation? And it's this, it's when you have host bone and it's completely engulfed and trapping host bone trabecula. 1986, Dr. Joe Mera, who again is a giant in the world of bone pathology, and he likes long descriptions. In his book, if you've ever read it, it's the 1980s, it's a very good book, but he goes on, he's very good in a descriptor. But what he and Dr. O'Brien described and cautioned about is when you're looking at bone with cartilage tumors, don't get mistaken by this encasement of metaplastic bone that can be seen in benign enchondromas, and that's not host bone permeation. Well, let's put that, let's apply that to a case. Okay, 54-year-old male, lesion in the proximal humerus, and this is a curettage. We can see that it's a hyaline cartilage tumor, not all that cellular, a lot of bone, and is that host bone entrapment? How about in here? Is that host bone entrapment? Does that make this a chondrosarcoma? Well, you get the drift on how helpful these images are. This is an enchondroma. I mean, they probably didn't even have, I don't even know if they needed to curette it, if there's pain or maybe worrying about a fracture. But this has to be an enchondroma when you see that image, or it should be. Well, what are we seeing here? Well, this is that encasement of the host of the cartilage tumor. This metaplastic bone. It is not inside and enveloped by the tumor. The other problem with these curettage specimens, of course, is that you're getting host bone all fragmented and mixed up in the hyaline cartilage tumor, and that makes it hard sometimes. Is this host bone entrapment? There's cartilage up here, there's a little bit of cartilage up here, there's some bumping up there. Is that host bone entrapment? Well, this is what you need to see in true host bone entrapment. You need to see a completely tightly enveloping host bone, not a piece partially, not just bumping up, but this is true host bone entrapment. And it's easier to see once a tumor's out, and hope you got the preoperative diagnosis right, admittedly, but you still can see it in smaller pieces of tissue. Here's a 65-year-old woman who came with a biopsy tissue of a lumbar vertebra lesion, and you can see that, yes, we've got some host bone completely entrapped by what looks like cartilage here. We go to our imaging, that's a compression fracture. And I show this to caution you again that when can you see things that really look a lot like and almost interchangeable with host bone permeation? It's in compression fractures in the spine, and if you look at the skeletal distribution, you'll see the chondrosarcomas of the vertebral column are really pretty uncommon. So that should be one clue you got to be careful. But as seen in this case as well, or this is the same case, I'm sorry, this is probably non-neoplastic fibrocartilage, and you can get callus even in fractures catching this bone and making it look like host bone permeation. And here's another one, same thing. Well, you can see reactive bone here is just a sliver of what I think is non-neoplastic cartilage trapping some of this bone in a fracture. So be careful. What about myxoid change? Well, this had been mentioned in some of the larger series of chondrosarcomas through the years, but it was really this article. This is my mentor, Dr. Chris Zuni. A wonderful guy, stellar pathologist, and so much fun to work with. I miss him very much. He retired in 2006. He's a great teacher, and he and his colleague, Dr. Johannes Bjornsson, and Doug Pritchard, who was the orthopedic surgeon on this paper, they looked at a lot of chondrosarcomas, 344. And in that group, they, from a pathology standpoint, felt that they saw evidence of myxoid matrix or myxoid change in 87%. So it's seen in a lot of these tumors. It doesn't mean you can't make the diagnosis without it, but it is really pretty common. But you find as you're reading through these papers, you say, okay, good, myxoid change. Now, what's that? Well, if you try to read the descriptions, you'll see there's a myriad of different ways it's described. So what does it look like? That can be problematic. 65-year-old female, distal tibia. The lesion is maybe moderately cellular. There's a few big cells here. And what about this matrix? It doesn't have that clear blue look. It's kind of messed up, and you go, well, is that myxoid change? Well, here we go. It's another enchondroma. And what is that stuff? What's wrong with that matrix? Well, it's degenerative change within the matrix. And you can see flat out necrosis in enchondromas. So that's not myxoid change. You got to be careful. It's kind of degenerating, but it's not myxoid. This is what this myxoid change is. And I tell the residents, it's like gloppy stuff. Slimy, gloppy, slippery. It just looks like it's not breaking apart. That's a good example of myxoid change. So we've discussed some of these articles in some of these series dating back to 43 and up through 1999. We've got tools, but increasingly over time, it still became clear that people are having problems, even though we have these tools, making the diagnosis. And this group decided to prove it with some data. And this is a paper that was published in 2009. And this is a group primarily out of the Netherlands with Pancras Hagendorn and Judith Bovey, excellent bone pathologists, and others. And so this is one of those kind of studies, whatever specialty you're in, where they grab some cases and they send it out to people who are experts and say, what's your diagnosis? Come back and say, how well did everybody do? I think they had, I don't know, I think it was 16 pathologists. I happen to be one of them. And, well, they found out what they thought they were going to find out. And they found out that indeed there was quite a discordant results between these pathology diagnoses. When we're looking at the distinction between enchondroma and chondrosarcoma, and you can see here that the kappa coefficient, kappa coefficient was 0.54. Not good. And the other thing is there were a hard time with grading these tumors between grades 1 and 2. Once they got in the malignant realm, kappa coefficient of 0.8. Okay, so that's a problem. Well, at least they documented it, I guess, because we kind of knew it, but it was a very interesting article. But the other thing they did is they looked at a group of cases that they felt were indeed chondrosarcomas based on panel of people, long-term follow-up. And they said, what are the histologic features that are helpful in making this distinction? And, well, they found the 4 criteria that we've been talking about. Myxoid degeneration, host bone entrapment, high cellular and open chromatin. You know, it would have been nice if there had been something else, but they confirmed that these still are the most helpful features. And of those, they found that the mucoid matrix and the host bone are probably statistically the most important or helpful features. Okay, what about the grading? Well, over the years, there have been a number of different grading schemes proposed for chondrosarcomas, and the reason is because there's nothing that, you know, it tends to be poorly reproducible information that we get. And so in these variety of different schemes, all of them include in their schemes cytologic features in the cellularity Tibia. And some, I don't know about many, but at least some include mitotic activity. Okay? Well, what about that mitotic activity? Well, the first time this was really closely assessed was in this 1977 paper by Dr. Harry Evans and Alberto Ayala at MD Anderson. And in this study, they looked at 71 cases of chondrosarcoma, and they used these factors. And what they found is they felt that mitotic rate was an important factor to look at in grading these tumors. But if you look at the data, of these 71, 32, there were no mitotic figures. So right away you know it's not going to be helpful in distinguishing enchondroma from low-grade chondrosarcoma or grade 1. What about grade 2? Well, of the 21, less than 2, they were scarce. So not all that helpful. And in grade 3, greater than 2 per 10. And I think that this is a reproducible study. It's a very good study. These are excellent pathologists. So it's a little bit curious that it could be helpful. And in fact, I don't use mitotic activity. I think it's in the WHO. It's talked about as mitotic activity, but I find them kind of hard to see in those chondrocytes, and I really don't use it. And I think this backs up why. One of the things you see here is a smaller proportion of cases. The distribution is pretty similar to other series, and that most tumors are in grades 1 and 2. Okay? But if you want to count them, go ahead. That's why I'm not a neuropathologist. I don't like that. Anyway, what about histologic grade? Well, but it still is important. All the big series still show that the the most important independent predictor of biologic behavior is the histologic grade. But not too surprising, look at this range in grade 1, 2, and 3 between series. And these are big series from big institutions. 13 to 60% grade 1, 35, 67, 3 to 16. Now there's outliers when you see a range, but I would say that in general, most of them are closer to this end. But it just illustrates the problem. When we talk about chondrosarcomas in grade, in general, grade 1 is considered low grade and grade 2 and 3 high grade. Well, if you're going to compare this, let's look at the survival data with all these different series lumped together. And of course, as you would expect, the 5 and 10-year survival, there's quite a range. But grade 1s really do quite well. Very, very few metastasize, and of those that have been called that in the literature. Grade 2, a little bit worse and then worse. If you're going to get metastatic disease, it's likely a grade 2 on the end of closer to grade 3. So we've kind of talked about criteria for benign and malignant, and we've talked about some grading ideas. But one of the things I'd like to focus on now in the next couple of slides is this area. What about those tumors that kind of are right in between Enchondroma and grade 1 chondrosarcoma? And through the years, they're the atypical borderline tumors, but they've gone through a myriad of different terms used for them. But even in this paper by Dr. Dahleen, and I knew him too, he was Dr. Dahleen was before Chris Uni, and I knew Dr. Dahleen. He'd retired by the time I was on staff, but he was frequently on the floor and go out to lunch with him a lot, and he's a wonderful man from South Dakota. I'm from North Dakota. And so he was really the one that started bone tumors at Mayo Clinic, and he devised and put together a registry of tumors that's amazing. I still have it outside my office, and you can go and pull out a drawer and pull out the slide from, I think it was the oldest slide for osteosarcoma is in the year 1901. And you can still make the diagnosis on the slide. So it's pretty amazing the work he did, and you can see he tabulated all of this, and of course now he didn't have the advantage of all these computerized systems. Anyway, I could go on and on about him, but suffices to say in this article in 1956, it's a great article, 212 cases, and he did say in the pathology part of this that the experienced observers emphasized the difficulties in diagnosis of some borderline lesions, and in that 43 paper of Lichtenstein and Jaffe, they said the same thing. Wow, here are all the terms over the years that have been used for this group of borderline tumors. Look at this, atypical enchondroma, clump, cartilage lesion of uncertain malignant potential. Whew. Grade 1/2. Aggressive enchondroma, active enchondroma, well that's grade 0 and low-grade cartilaginous tumor. Well, it is kind of hard sometimes to try to figure out a name for something that you don't understand. Okay, so in 2013, people at the consensus conference for the new WHO book, everybody knew that this is a problem category. We got to get rid of all these terms and do something. And so that was one of the goals at the consensus conference. I was fortunate enough to be at this conference, and it was an interesting discussion. Well, their consensus conference, it's not unanimous, it's consensus. And the consensus vote was to do this, to take these atypical cartilaginous tumors, use that for that whole group, and lump it with the grade 1 chondrosarcoma and come up with this term, atypical cartilaginous tumor, ACT, / grade 1 chondrosarcoma. Doesn't that clear it up? In my opinion, the value in it is at least there's an official thing that says one term. That's progress. And what to do? I mean, we still don't really understand that category, so in some ways the term reflects it. But I have an issue a bit, I must say, putting a malignant term in this, lumping it with a non-malignant entity. But anyway, okay, so we got a term. How do these things behave? Where do you put it? Well, in the prior editions of the WHO Bone and Soft Tissue book, if you're familiar with it and you see in the soft tissue world, there's been this benign, then there's this intermediate category, and then malignant. Well, we've been fortunate in bone. We kind of are lumpers, not splitters. And that category was not in the old edition. But in the new edition, it's added. And this new term, this ACT Chondrosarcoma 1, was designated as intermediate locally aggressive. Okay, so not malignant, but notice that grade 1 chondrosarcoma is in the term. A little bit cumbersome. So here we go. In the hyaline cartilage tumors, currently this is what we have. Okay, our benign, intermediate, malignant. Well, then what are the diagnostic criteria for this category? Well, unfortunately, they're not really clearly defined. The reality is, I think, that this still lumps together a group of tumors and that fall in a spectrum. There are some that fall closer to this end, and there are some that fall closer to this end. And they do so based on criteria that we use in features that include both the histologic features and the imaging findings. So when we think of this concept, you can't make the diagnosis purely on histology. You have to have the imaging, okay? Well, what do the radiologists look for when they're looking at these hyaline cartilage tumors? And these are the primary imaging findings. And if our radiologist says, oh, it looks malignant, I say, well, why? Tell me, is there a soft tissue mass, or is it just eroding the cortex? How much cortical thickening? Because for me, I know in the spectrum, if I'm seeing kind of a, increased cellularity, I'm putting all this information together. But anyway, these are the features that they look at. And if you translate this into the long bones, you'll see that in enchondromas, they sit in the middle. They're not affecting the cortex at all. In this intermediate category, you start to get scalloping of the cortex. Not destructive breakthrough as you see in a chondrosarcoma, but it scallops, it expands. It's not just sitting nicely in the middle. It's doing something to the cortex, but to a varying degree. And those that are closer to chondrosarcoma will show more features than the scalloping. So what's happened now is this. When we're dealing with hyaline cartilage tumors in the long bones, the treatment approach for the surgeons is we get a break, because now they really go after these things largely based on what the images show. Can't believe it. The radiologists, they got to make a definitive call for those surgeons, and we get a break because over time they would biopsy these things. And we'd say, oh, it's a hyaline cartilage tumor. Well, is it benign or malignant? Well, I need more tissue. Oh, you always say you need more tissue. I mean, how many times, right? And so now in the long bones, they really depend on the radiologists, okay? And if the radiologists aren't that worried, they'll either observe or they'll curette it out. If the radiologists see the scalloping, and again, it's to what degree, and those other changes, they'll curette them and do local, with adjuvant local therapy like some phenol, or I forget what the other thing is. It's just some local stuff they put in there. They would laugh.
Doesn't sound very scientific.
No, I mean, I'm thinking I should have looked up that again, but I can't remember. Phenol I know is one of them, whatever. They wash it out, how's that?
Good.
There's no surgeon in here, otherwise I can see them laughing right now. Anyway, but if they think that the imaging findings are beyond what you can accept in an intermediate, ACT, grade 1, the surgeon has to go in there and resect. That's a big operation. And that's the thing with bone tumors, and the scary thing about the diagnosing bone tumors is that the consequences of your diagnosis are big. They whack out bones and things. So it's a little nerve-wracking. So now the radiologists have to share that burden with us.
Excuse me.
Yes.
Is it generally thought that the grade 1s, if you want to call that,
Mm-hmm.
do not progress and evolve into a true chondrosarcoma?
Mm-hmm. That's an excellent question. And I think that the answer is twofold. I think that, yes, my personal opinion is that there are some tumors that progress. And in fact, there are enchondromas that progress. Very rare, but I've definitely seen cases of enchondromas over time. Now, one would say, well, how do you know it was an enchondroma? Because the ones that have progressed, you either are saying that based on a totally benign-looking image that over time gets worse, or recurrence of a tumor, and then one might argue, well, was it that all along? So it gets complicated, but based on a very benign-looking x-ray and over time it getting worse, I think that, yes, enchondromas progress. So indeed, a grade 1 could progress. If an enchondroma can do it, then a grade 1 can. But it gets to be a circular argument, because then one would say, well, was it really a grade 1? Maybe it was a grade 2. Without some sort of very firm objective way to measure this, it would be hard to say. But I think there's no question that, yes, some benign-ish looking tumors can progress. Now, one of the arguments at the consensus conference for lumping those together is that the large series out of great institutions have shown that a very small percentage of grade 1 chondrosarcomas will metastasize. But it's very small. To some extent, it's kind of similar to that, not the same, but similar to that argument of what do you do with well-differentiated liposarcomas in the extremities? Are they cancer or not? Well, they can de-differentiate, let's call it that, but then they don't want to call it that. So we kind of went through that with soft tissue tumors.
Has anyone taken those cells, put them in tissue culture, and seen them evolve into malignant appearing cells then?
I don't know the answer to that. I think of it as something that happens over a long period of time, so I don't know how long you'd have to wait to see that. And I wish I knew enough basic science to give you a better answer than that. I'm not aware of it. It's an interesting question. So here we have a 30-year-old patient, and you can see that this lesion, there's scalloping. It's a smaller bone. When it's a smaller bone, you might get more scalloping. And the MR shows it's more extensive than you can see on the plain film. And that's why you have to have more than just, plain films are so important to the radiologist, particularly with this type of tumor. But really, you got to get the MR and CT and get a look at it. And you can see here that it's quite extensive, but it's not breaking through the cortex. So the radiologist in this case felt it was this atypical ACT grade 1. It was curetted, and histologically, here's what we see. Some a little bit degenerative change. This is degenerative change. It gets pretty cellular, and there's some atypia. So for me, I'm uncomfortable with this. I know right away it's not an enchondroma, and I'll start looking for host bone permeation. And on higher magnification, everything looks bad on higher magnification, but still, this is worrisome. It just kind of looks worrisome, jumbled up, hyperchromatic. But with that image and no permeation, the diagnosis is this ACT grade 1 chondrosarcoma. Okay? Well, then what is the role of a needle biopsy for us in these cartilage tumors? Well, our role sometimes is a surgeon they go in, the radiologist says, this is a blah, blah, blah hyaline cartilage tumor. But if they're going to go in and do a big operation, they want to have something on the chart. So they can be okay now with just hyaline cartilage tumor, as before they were antsy about that. But sometimes now they just want to confirm it's a hyaline cartilage tumor. Fine, now I can go do my operation. But sometimes the radiologist didn't get right, and sometimes we tell them, well, it's not even a hyaline cartilage tumor. And then some of that, it's a dance. Maybe how experienced is a radiologist. It's a dance between the radiology and the surgeon as to whether they biopsy some tumors that they think are hyaline cartilage tumors. And sometimes the surgeons will biopsy more worrisome areas. Is it a de-differentiated chondrosarcoma? But importantly, with a needle biopsy, you really can't grade these tumors. I would say that some of them just look bad. You might get host bone permeation, and if the radiologist is telling you it's an enchondroma, you can tell the surgeon, like, I'm really worried about this. But if it looks not that bad and the imaging is bad, you just shouldn't grade these, I think. And on a needle biopsy, I'll say hyaline cartilage neoplasm, the combined histologic and radiologic findings are consistent with chondrosarcoma. Okay? Now, really, when the imaging looks bad, the histology looks bad. I had some slides, I took them out in here, but you look at a slide, the needle looks really like it's got to be a chondrosarcoma, and then you look at the image and it's bad. They already knew that. So anyway, don't try to grade on needles. We've talked about long tubular bones, but with these hyaline cartilage tumors, we have to start thinking in other terms when we deal with other anatomic sites. And I'll just briefly mention these short tubular bones. Enchondromas, the most common location is the small bones of the hand. And they can look bad. Big cells, very cellular. Never make a diagnosis of chondrosarcoma in the small bone just based on this finding. And they expand the bone. It's a small bone. And they get fractured because it's small. And then host bone gets mixed up. But imaging is so important, and really they do look bad when they go bad. A very small percentage of patients do develop chondrosarcoma. They're usually older patients, but the imaging for these enchondromas is really pretty classic. And this is what you see, destructive permeation of bone in chondrosarcoma, the small bones, not this pushing margin or this encasement. But look how bad that looks. Enchondroma. The flat bones and the spine and the sacrum. Now, this is where that term is not really well defined. Okay, what are the flat bones? Well, I have them listed here. And the spine and the sacrum. And the problem is that when you get recurrent tumor in these areas, it's much more serious than it is in the long bones because it's much more problematic to get it out. and bigger surgery. So they really want to avoid that. And so I think this is that tricky area where that term becomes a really pretty murky. This is a recent case, a 33-year-old female who complained of hip pain over the past 3.5 years, worse with activity. Imaging showed this acetabular lesion, not very big. Look here. I'm saying, well, is there any cortical erosion? What's this? And then the MR showed this lots of myxoid change, which we know in our pathology is kind of worrisome. And it did show that it was kind of eroding through and just barely ever so softly getting into the soft tissue. She's only 33, young person if it was chondrosarcoma. Well, this is a needle biopsy, and a lot of bone. Well, come on, where's a tumor? Well, there's some down here, and in another area there is more tumor. Well, this is not a grade 2. This looks neoplastic. Sometimes you just have to be sure it's neoplastic, let alone, grade 1, 2, or 3. This is all jumbled up, the spindling and the hyperchromatic nuclei. To me, this really is, no question, neoplastic and worrisome for whatever you're thinking is a chondrosarcoma, but overall, not much atypia. And here we got a little fragment. You might be convinced it could be host bone entrapment. What's the diagnosis? Well, if you say enchondroma, they might do a curettage. Chondrosarcoma, internal hemipelvectomy on a 33-year-old. It's a lot of responsibility to shoulder. And in this term, well, what are they going to do in the long bones? They curette it out. Or they might do an internal hemipelvectomy. And so these flat bone lesions, it so emphasizes you have to have a conversation with the surgeon. What are the consequences of my diagnosis? What do you understand this diagnosis to mean to you? Because I can tell you what it means to me. And it's a dance. It's putting all the information together and then sitting back and deciding what's the best way to proceed in a case like this. Now, your surgeon may say, well, look, I think it's got to be a chondrosarcoma. It's eroding the cortex. I don't want to go back. It's a flat bone. It's got to be a chondrosarcoma. But they may say, I got to do an internal hemipelvectomy. I don't want to have an intermediate category diagnosis on the chart if I'm going to do an internal hemipelvectomy. Can you help me out? Can you shoulder it? Well, again, you just have to take a case by case. In this case, I felt comfortable calling it chondrosarcoma, getting it on the chart. They're going to do an internal hemipelvectomy, and I felt that I felt comfortable doing that. They did the resection, internal hemipelvectomy. Here's some pieces from it. Increased cellularity, but guess what? It did have quite a bit for that little thing, host bone entrapment. It's a permeative lesion, more than you might even the eye imagine. A lot of this entrapment. And this is the most, in my opinion, the most important criteria for it's got to be malignant. And so there you go. And there's the procedure. So sometimes it's a matter of style. I don't know, some bone pathologists may say, I would have used ACT grade 1, fine. I prefer to go with a grade 1 in this case. And this is just showing what happens. Here's the case that I just shared with you. The growth shows of this erosion here. Not a lot, no big soft tissue mass. But eventually this is what happens. It starts to creep out and becomes much more of a problem and a high risk for recurrence and metastasis. Here's a 51-year-old male, hip pain when bowling. MRCT, no soft tissue mass, and so they went in. They were thinking, oh, I know. So this was a few years ago, and the surgeon, Dr. Frankston, went in thinking, I'm going to do I'm going to get a frozen and decide what to do on the frozen. My colleague Les Wold, another great bone pathologist at Mayo before me, he was in the frozen section lab. It was a late night. This isn't our stain for our frozen, but based on the frozen, he said, I can't call this chondrosarcoma. It's a borderline tumor. And so Frank said, well, okay, I'm not going to do a hemipelvectomy. I'm going to curette it. Well, 2 years later, darn it, this thing's coming back and it's not looking good. Went in, did the operation. It's a dedifferentiated chondrosarcoma. Oh, my goodness. The imaging to begin with was kind of, borderline, but it just goes to show how you got to respect these tumors in that location. 47-year-old male, incidental finding during open heart surgery. So it's on the frozen section lab. My colleague, she gets a call. It's a cardiac surgeon. And, I'm seeing something here. There was a normal chest x-ray, but there's something here. Send it in. And we noticed a small 1 centimeter nodular mass in the sternal marrow at the lower end and frozen section revealed enchondroma. And I saw the tissue on this. It looks totally benign. Well, look at this 2 years later. What in the world? And again, it emphasizes the importance of being careful in these flat bones. Do I ever make a diagnosis of enchondroma in a flat bone? Yeah, I'll use the term maybe atypical / grade 1 with the notion that sometimes the surgeon may curette if it's a tiny, little, teeny incidental finding. And some pathologists may diagnose this in enchondroma. Never say never, but in the big picture, I tend to not use the term, period.
Could these be situations with tumor progression over that period of time?
It could be. But the surgeon at that time, in only 2 years' time, scooped it out.
I know.
Who knows? I mean, it seems impossible, doesn't it?
Yes.
It really just seems impossible. And of course, I don't know. I think that is the case of tumor progression.
Right.
So we know that I've been talking about the treatment. Well, these cartilage tumors are not radio sensitive or to chemotherapy. So surgeries at this point in time is the only thing they have to treat these patients. Well, what about some help for us, ancillary studies? Well, over time, biomarkers, all these tests have been done, nothing is helpful. Up until 2011, when this group from Stanmore in the UK, Dr. Amory and Adrian Flanagan have done wonderful work in the molecular realm of bone tumors. And they published this article in Journal of Pathology in 2011. And what they talked about is they identified IDH1 and 2 mutations in little over half of central and periosteal cartilaginous tumors. Finally, something from a molecular thing that might be of some help. Well, you break down those tumors, though many more were positive in the acral tumors, the hands and the feet, half in the long bones, and only 35 of the flat bones, which is unfortunately where we need the most help. Well, we all know they're not unique to cartilage tumors, and we know from brain tumors, they've been talking about that for quite some time, and gliomas, but they're also hematologic, prostate, colorectal, and it keeps growing. The tumors have these IDH mutations, but they're in cartilaginous tumors, they're early events, and they're seen in both benign and malignant. And that's the important thing. It's not going to help us with enchondroma and chondrosarcoma, but it still does have some diagnostic utility. And if you see if you delve into the IDH mutations, you can see that in the IDH1 gene, it's the it's R132C and G. So most of them, that's 48, are in this codon. And then a much smaller percentage in the 172S, okay? And that, in other studies, have backed that up. Well, great, then we'll use an immunohistochemical stain. Well, no, not so, because here, this is what the current immunostain shows. It's this 132H. But in cartilage tumors, only 70% are positive for this. It was C and G of the 132 and the IDH1 that I mentioned on the prior slide. So immunohistochemistry is a very low value, and you have to do molecular testing. We've done pyrosequencing over the past few years, but now we've switched to next-gen sequencing because it's much more sensitive, okay? But to do that, always this thing is recurring, and Emil knows this, we need tissue that's not been decalcified to do molecular studies. No decalcification, acid decalcification. And this is why we can't do the elegant studies like the soft tissue people have done, because we're going to do archival studies. Most things have been decalcified. So we're working on it and trying to move forward because we really need more molecular studies in bone pathology. I would just add that dedifferentiated chondrosarcomas also have these mutations, and they're found in the low-grade and the high-grade components. And these two studies have borne that out, as you can see from the data here. So when it doesn't help enchondroma, chondrosarcoma, when can it help? Well, this is a scenario that sometimes happens where you've got this big mineralized mass in the pelvis, and the radiologist said, I don't know, it could be a chondroblastic osteosarcoma or it could be chondrosarcoma. Well, how does that matter? Well, it's a big difference because osteosarcomas get treated with neoadjuvant chemotherapy, and chondrosarcomas do not. And if you look at the histology of these, you can see that if you put a needle biopsy in this chondroblastic osteosarcoma, you're diagnosed as osteosarcoma. If you put it down here, it's going to be chondrosarcoma. That's a problem. Big difference in treatment for these patients. So these two studies, it's again this group from Stanmore, Amory, and Adrian Flanagan, and this Kerr paper is from the Mass General. And of these chondroblastic osteosarcomas, none of them had these IDH mutations. So I do think that that's helpful to do this in that situation. If it's negative, so it's not, if it's positive, it's helpful. If it's negative, it's not, right? Because only 50% of cartilage tumors. And chordomas are so far negative, but all you need is immunostains for that differential. So here's an example of a 64-year-old male in the right ilium, and we've got this spindle cell thing, and this is neoplastic cartilage. It looks bad. Is this a dedifferentiated chondrosarcoma? Is it a chondroblastic osteosarcoma? What are we going to do? The radiologist said, I don't know. Well, this would be the example, I think, where IDH, it would be worthwhile to at least try it. And we did in this case, and it was positive, so just based on that, I feel comfortable telling the surgeon it's chondrosarcoma, no chemo, but still do the big operation. Okay, as we move into the last few minutes of this talk, I'd like to go back to our case. Well, is this any easier? I'm afraid not. We got a 9-year-old, he's got this thing here. So it's cellular, no host pome permeation. It's a weird case, and you'll find out it's even more weird than you think. I called it this. I cringe when I use that diagnosis, but I do that when there's just these nuances that it's just not so straightforward. I mean, you know, we resect this guy's face. Are they going to go back in? What are the consequences? Got to be careful. There's a high likelihood that this thing is going to recur locally, is my feeling, and that's what this kind of category is at risk for. Currently, he's NED at 3 years. Skeletal survey was normal. He's a young kid, you do that. But what's with this? A child with bilateral low-grade chondrosarcoma, and why do we know it's bilateral? Well, I'll tell you in a minute. Oops, I didn't know that I kept that on that slide. We did some cytogenetic data on the patient. The left mastoid, and that tumor I'm shared with you. Conventional cytogenetics, no clonal abnormality. On the blood, high resolution CGH microarray, no relevant copy number changes or regions with absence of heterozygosity. But we knew this. I cheated. 6 months earlier, he had right-sided hearing loss, the opposite side, and facial paralysis secondary to a mass in the right mastoid. We didn't have the slides, but we knew this history. Long-standing hearing difficulties, facial nerve paralysis. And that right side was treated with it's a big word, tympanomastoidectomy. And here is the opposite side. Same thing, hyaline cartilage tumor. This is blood. They have a lot of hematoxylin. It pretty much was the same. Now it's on both sides. Oh, but it gets even more interesting. He has a brother, shared biologic mother, father different, presented who at 10 years with bilateral nerve paralysis and conductive hearing loss. And this is his. This is the brother, the half-brother. And this is the histology. It's the same darn thing. But get this, the mother. She says, well, I had, when I was 12, what they called a low-grade chondrosarcoma resected out in Washington State. She was treated with adjuvant therapy and chemotherapy. And at this point, no big recurrence of disease, which made you wonder, you know, that young boy, the mother's gone all this time and not, you know, had a problem. Three family members, low-grade bilateral. All affected members presented in childhood. No other known cartilage tumors, likely hereditary, and did not fit with any known syndrome. So at this point, we published the paper, you know, of this case report, but thought we got to look into this further. So we went on to do whole exome sequencing of the blood and tumor tissue to see if we could find a causative genetic mutation. And this is where I turn to my colleagues in individualized medicine, because I am not a basic researcher. But it just shows it takes a village. We got all this crew over there that this is what they do, and we got a great case. Can you help us out? And look at this. What we found is an IDH1 pathogenic mutation in the blood and the tissue of all three. Our patient, the half-brother mother, and the father of our index patient, who's not related to the other two, he was negative. So this suggests that this is not a somatic, but a germline or hereditary IDH mutation that's never been described. What an amazing case. So, I mean, the papers, I hope maybe 2 weeks from being sent off to publication. We're almost there. And so hopefully within the next few months it'll be in the literature.
What are you naming it?
Why?
Not yet.
No name yet. Descriptive. Not atypical, I'll tell you that.
Right.
So we suspect it's a familial bilateral chondrosarcoma of the mastoid, novel syndrome. It's got this germline mutation, all members, and to date, no affected member has evidence of glial neoplasm or hematologic disorder, because this mutation has been identified in other tumor types. So it begs the question, do they need to be followed more carefully for the occurrence of another tumor type where we know this mutation occurs? So in summary, I hope I've emphasized with you the importance of this multidisciplinary approach. We use these parameters. We take it all into context with a lot of other information. We don't have anything else at this point for the most part. This is that goofy category that I think I do applaud the fact that at least there is one term. I don't want to diss it too much. It requires a lot of talking and communication to figure out what's the best way to approach these patients. In the flat bones, It needs to be done on an individual basis. Treatment, as we've discussed, when you make a diagnosis of chondrosarcoma, and in that I mean maybe a 2 or 3, it's a surgical resection. Because most of the time, unless it's a flat bone, they're not going to do a big operation with a grade 1 ACT. Still related to the grade for prognosis. And at least we have something, this IDH mutation. If it's positive, it's not going to help with benign malignant, but will help you from a chondroblastic osteosarcoma or maybe some other tumor. But of course, as with so many things, we need more objective evidence from delving into these tumors. We can't go any further with what we've got. We need to get more molecular information. And this case that I shared with you, I think is exciting, and it shows how as we move into these on a molecular level, that the evolution of these diagnostic concepts, there's hope, and I think we're getting there slowly. So I certainly want to acknowledge all my colleagues, and a lot of these are in the individualized medicine. Some of them are in genetics and where else? Erically, and the individualized medicine researchers and whatnot. Patrick Blackburn was a fellow who will be first author on that paper. He's a fellow, and he did a lot of work, and he's a great guy. So thank you very much.
Questions for Dr. Inwards?
Yes, Pari.
Hey, Dr. That was a great talk. Thank you so much. It was very informative. So you mentioned this mixoid change, and I think that's a very valuable finding. We always look for it. But my question is this. There are some groups, the MD Anderson group in particular, who think all mixoid change in cartilaginous tumors should make them fall into grade 2 chondrosarcoma directly. I think in some cases it works out well, but in other cases I find it a little bit dicey because we even see what are radiologically clearly enchondromas that have foci of mixoid change here and there, and of course it's a spectrum. So I mean, is it prudent to categorize all mixoid change in cartilaginous tumors as directly grade 2 chondrosarcomas? Of course, we're going to look at the radiology and all that, but still, what do you think of that histology finding on its own?
Well, my personal opinion is I wouldn't do it based on that histologic finding alone. I know that the Anderson group does that, and they have some data in their paper, and all I can say is that for me, I wouldn't. I think that any of these criteria, except for host bone permeation, that's the only one criteria. But when you see it, there's other things too. That's the one, much more than any of the others, if it's not a compression fracture, that I would use. Not mixoid change, and in part, like you said, and I shared with you all the descriptors, sometimes it's hard to tell if it's really the right mixoid change. So it's my opinion that you need more than just that.
Yes, John.
When you have major discrepancies between radiology and pathology,
Yep.
do you lean more towards radiology when you sign it out, or do you lean more towards pathology when you sign it out?
Okay. Well, I'll tell you. The thing about this is I make it more simple than it is. Then what happens is how, I don't want to say good, how experienced is your radiologist, okay? So what I do is I call different radiologists. I mean, if I'm hearing from one radiologist something doesn't make sense to me, I go find another radiologist and then another one. Not until I find someone who agrees with me.
Get the right answer.
Always. I'll give people a shot to get it right. But, it's like with pathology. You walk a slide around, you're going to get different ideas on things. And that's what we can understand is that interpretive thing that you can't put into words. I'm fortunate I got a couple of them that are just stellar. I'm spoiled. They make it much easier for me than other people. But I still think, I'm a pathologist. Histology is still trump. And I think there's no question that there are cases where the radiologists miss it. No question.
Yes, Dave.
Did I understand you correctly as saying that cortical involvement, cortical thickening rules out an enchondroma?
Well, if you have scalloping, that'll put it into the, good scalloping will put it into the category of an atypical / grade 1. The thickening is another story. Oh boy, radiologists, people disagree on that. If it's in the lower part of the femur or the mid shaft metaphyseal, it's really thick and expanding, our radiologists say you've got to treat that. And some surgeons would say you should resect that and not scoop it out. That's one location where it's like this. So thickening is usually not a problem, but if you get it in the right location, it can be worrisome, and they may resect. But if you see the thickening, you're going to see other things, more scalloping, not an even distribution of the matrix on the imaging. You're going to start to see other things.
Just for context, I got a biopsy of a femoral mid-shaft lesion in a 9-year-old, I think. And I called it a low-grade cartilaginous neoplasm. And then it was one of those situations where they were just trying to confirm that it was a cartilaginous tumor. A couple of days later, I got a curettage, and it was entirely low-grade cytology, no myxoid change, no host bone entrapment, and I called it an enchondroma. And now I'm
Well, I think that in that case, I'd go by with the radiology, and if they scooped it out, they're probably not going to care. And that's it. The other idea, this thing with the terminology. I personally, and I a lot of people use the terminology, what you said. From my perspective, I always, in bone and soft tissue, I stay away from saying low grade something or other if I'm not calling something malignant. And that's the problem with this terminology. If I say low grade, surgeons will hear low grade, they think malignant. And I've seen at conferences where they say, well, you told me it was a malignant. You said low grade, but they said, well, I said it's something about the lesion, like that. They get confused by that. So I would just caution using the term low grade unless you really believe something is malignant. And in this case, while we got a malignant diagnosis, that's not really treated like a malignant tumor. So that's why I don't like that term. I would be careful, but I think that, you know, you go with what you see and combine it with the radiology. There's no hard and fast answer to that. I don't know if that answers your question, but.
Also depends on what your surgeons really understand when you say something.
Yeah. Communication.
Flesh marks, this means that.
Yeah.
Just a comment, for historical perspective, Darlene's daughter worked here for about 20 years.
Oh, she did.
And she was the EM tech in my lab, and
Ah.
she was just outstanding and a delight to have around. And she told me a lot about her father.
Oh, yeah, she's yeah.
The other
And her
thing-
mom. Her mom was great.
Yeah, I
too.
didn't know her, but
Helen,
the
yeah.
other interesting thing, what's so fascinating about this, and a lesson for the residents and fellows, is another former faculty member, and actually was head of pathology here, though a pediatrician, was Bob Good. And he would talk about his patients and the experiments of nature that were occurring that would show you so much about things. And, you know, the patients are talking to you, and also the slides are speaking to you also. So you just never know what you're going to find when you see a case. You know, this is just fascinating. So, thank you.
Oh, sure. Makes our job fun, right?
Yep.
Any other questions? Thank you very much.
Thank you.